Brief psychotic disorder is a short-term mental illness. Look at this picture shows that delusions, hallucinations, behaviors. Look at this. And brain images, CT, MRI, made used to diagnosis. Detail going on. Introduction. Brief psychotic disorder is a short-term mental illness characterized by the sudden onset of psychotic symptoms such as delusions, hallucinations, disorganized speech, or grossly disorganized behavior. The condition is transient and typically resolves within a month, while it can be highly disruptive. Individuals often return to their baseline level of functioning with proper care. Definition. Brief psychotic disorder is characterized by the sudden onset of psychotic symptoms such as hallucinations or delusions lasting at least one day but less than 1 month. It often occurs in response to a significant stressor and typically resolving without lasting impairment. Etymology. The term brief psychotic disorder is derived from Latin and Greek roots. Psychosis comes from the Greek psyche, mind or soul, and osis, abnormal condition, while brief originates from the Latin brevis, meaning short in duration. Together, the term describes a short-lived abnormal mental state involving a loss of contact with reality. Epidemiology. Brief psychotic disorder is relatively rare with an estimated lifetime prevalence of 0.5 percentage to 0.1 percentage in the general population. It is more commonly observed in women, particularly in the postpartum period, and in individuals exposed to high levels of acute stress or trauma. Types. According to DSM-5, BPD can be classified into three types. 1. With marked stresses. Brief, reactive psychosis triggered by acute stress, example death, accidents, divorce. 2. Without marked stresses occurred without a noticeable external stressor. 3. With postpartum onset occurs during pregnancy or within 4 weeks postpartum. Causes. 1. Stressful life events, example trauma, bereavement, accidents. 2. Substance use, intoxication or withdrawal. 3. Hormonal changes, postpartum. 4. Sleep deprivation. 5. Underlying personality disorders. 6. Neurological conditions, example epilepsy, encephalitis. Risk factors. 1. Female gender, especially postpartum. 2. Personal or family history of psychotic disorders. 3. History of trauma or abuse. 4. Major life stresses. 5. Social isolation. 6. Substance misuse. 7. Pre-existing mental illness, example mood disorders. Complications. 1. Recurrence of psychosis. 2. Progression to schizophrenia or schizoaffective disorder. 3. Risk of self-harm or suicide. 4. Social or occupational dysfunction. 5. Stigmatization. 6. Family distress. Pathophysiology. Pathophysiology of brief psychotic disorder, step-by-step process. 1. Exposure to a stressor or trigger. The process often begins with sudden and intense psychosocial stressor such as bereavement, trauma, or childbirth. In some cases, no identifiable trigger is found. 2. Hyperactive of a HB axis. Stress activates the hypothalamic pituitary adrenal HB axis, leading to increased secretion of cortisol, the stress hormone. Chronic or excessive activation disturbs normal brain function and emotional regulation. 3. Neurochemical imbalance. Stress and cortisol affects neurotransmitter systems. A dopamine increase, especially in the mesolymphic pathway, linked to hallucinations and delusions. Serotonin and GABA contributes to anxiety, agitation, and mood instability. 4. Disruption of brain circuits. Affected brain regions include prefrontal cortex, responsible for reasoning and judgment, causes disorganized thinking. Lymphatic system, linked to emotions and memory, influences paranoia and fear. Temporal lobe, associated with auditory hallucinations. 5. Onset of psychotic symptoms. Resulting from the above changes, the person experiences delusions, hallucinations, disorganized speech, and disordered behavior. Insight and reality testing are impaired. 6. Short duration and recovery. The symptoms typically last from 1 day to less than 1 month, With or without treatment, individuals usually return to their pre-morbid level of functioning once the stressor is resolved and neurochemical balance is restored. Signs and symptoms. 1. Sudden onset of psychosis. 2. Delusions, false belief, often bizarre. 3. Hallucinations, usually auditory. 4. Disorganized speech. 5. Disorganized or catatonic behavior. 6. Emotional turmoil or confusion. 7. Paranoia or agitation. 8. Impaired social occupational functioning. Diagnosis. A. Criteria DSM-5. 1. Presence of less than one psychotic symptom. 2. Duration 1 day to less than 1 month. 3. Return to pre-morbid functioning. 4. Not better explained by other mental, medical or substance included disorders. B. Diagnostic tools. 1. Mental status examination. 2. Psychotic interview. 3. Neuroimaging MRI CT to rule out organic causes. 4. Toxicology screen to exclude substance induced psychosis. 5. EEG if seizures are suspected. Nursing diagnosis. 1. Disturbed thought process related to acute psychosis. 2. Risk for self-harm or violence. 3. Impaired verbal communication. 4. Disrupted sensory perception, auditory or visual. 5. Social isolation. 6. Anxiety or fear. Medical management. 1. Antipsychotics. Example risperidone, olanzapine. 2. Benzodiazepines for agitation. 3. Mood stabilizers if mood component exists. 4. Monitor for side effects of medications. Nursing management. 1. Ensure a safe and structured environment. 2. Maintain clear and simple communication. 3. Monitor for hallucinations, delusions. 4. Promote reality orientation. 5. Involve family in care planning. 6. Provide psychoeducation. 7. Ensure medication compliance. Treatment. 1. Pharmacotherapy, short-term use of antipsychotics. 2. Psychotherapy, cognitive behavioral therapy CBT. 3. Hospitalization, if patient poses a risk to self or others. 4. Supportive therapy, emotional support, stress management. 5. Follow-up care, regular psychotic evaluation, post-recovery, psychosocial medicine. 1. Cognitive behavioral therapy CBT to address delusional thinking and improve insight. 2. Psychoeducation. Educate patient and family about the illness, medication adherence and stress management. 3. Social skill training to improve interpersonal communication and functioning. 4. Family therapy helps reduce experienced emotions and family stress. 5. Vocational rehabilitation supports return to school, work, enhance independence. Prevention. 1. Early identification and intervention during stress. 2. Coping skill training. 3. Regular mental health follow-ups. 4. Avoidance of drugs and alcohol. 5. Stress management stress strategies. Example mindfulness, relaxation techniques. 6. Support networks, family, community. In conclusion, brief psychotic disorder is a short-term treatable mental illness marked by sudden onset of psychotic symptoms, though alarming in presentation with timely medical and psychological and social interventions. Most individuals recover fully. Continued monitoring and psychosocial support can reduce the risk of recurrence and help individuals reintegrate successfully into their personal and social lives. Thank you. Have a nice day.